I don't know who you want.
Oh, Sam's gonna do it.
Oh, that's right.
Yeah.
Okay.
Okay,
Oh,
I'm
God,
just
can
gonna-
I get the? Oh,
Ah,
no! I need the keyboard.
There you
It's
go.
a little easier for me to.
Where's the keyboard?
It's right in front of me. Ruined it.
Here's the meeting. Well, this is the case I talked about this already.
Yeah,
Yeah.
exactly. All right, so little complicated history for this patient. So, and some unknowns as well. But basically, a 56-year-old female, she presents to Dr. Cohen's clinic with complaints of decreased vision since her recent hospitalization, or I guess it was a couple years back. She was apparently hospitalized after developing necrotizing fasciitis of her foot after stepping on a nail. She's
Roofing nail. You guys have roof work done? Probably not yet. Roofing nails are brutal.
yeah.
They're those little things that I brought so many tires to roofing nails.
So she tells Dr. Cohen she entered multiple organ failure with questionable DIC and hypertensive emergency, but we don't have those hospital records available. But pretty dependable historian. During her hospitalization, she was also diagnosed with type 2 diabetes with an elevated A1C. However, this has been better controlled recently. So the last A1C when Dr. Cohen saw her was less than 7. And then in addition to the surgery and antibiotics she received in the hospital, she also received adjunctive hyperbaric oxygen therapy to treat her necrotizing fasciitis. We'll have one slide on that. Before her hospitalizations, she could see well, except that she needed reading glasses. Now everything seems blurrier to her out of both eyes over the past 6 months in particular. She has a small shadow that comes and goes just out of the left eye. And then she hasn't had any recent eye exams before this one in clinic. She's concerned about the change in her vision over the past 6 months and maybe needing an update to her glasses. So history, type 2 diabetes, thyroid disease, surgical history was this foot surgery she had at the hospital. And then visual acuity wise, she's 20/80 in the right eye, 2100 in the left eye, and normal eye pressures. So first slide. Spent some time on this one on the airplane. Heidi and Kim were roasting me
It's younger than me.
as I was making this. Does anyone know how hyperbaric oxygen treatment can affect vision?
That's cataract.
Yeah, so number one, it can cause cataracts, and that would be more of a permanent kind of long-term side effect from it. Not as common, but what's the more common kind of reversible cause?
ROP?
Or not cause, but kind of consequence. So it can cause a myopic shift. And so that's what you mentioned, that there was just maybe a reversible vision changes with this recent hyperbaric oxygen therapy. So basically the high concentration of oxygen can cause toxicity. It causes hardening of the lens, which will increase that refractive power. But with these short treatments of hyperbaric oxygen therapy, it is considered to be reversible. And then cataract, like Matt mentioned, but that wasn't the case for this particular patient. All right, so keep in mind that history with the patient, her hospitalization, questionable DIC, hypertensive urgency.
So here's the problem. And I'm gonna, Doctor, we go kind of quickly because I have a giant retinal tear detachment.
Sounds good. So fundus photo of the right eye. Media is clear. The disc looks sharp and flat. There's some RPE clumping in the periphery, some intraretinal hemorrhages, especially nasally and within the macula as well. And there seems to be some hard and soft exudates within the macula.
Yeah.
Nice.
This is just zoomed in the macula. I think you basically commented on everything. Maybe some AV nicking as well. Just very, very mild. But and then you mentioned this RPE clumping. it's hyperpigmented, essentially a little bit more hypopigmented around these areas.
Mhm.
I have to say, when I saw her, I said, when was your laser treatment? And she said, I don't have laser treatment. I was like, oh, that makes you kind of interesting.
Yeah.
That's when we got all these pictures. So yeah, what do you think of those spots?
Yeah.
Yeah.
I guess we'll just get in more into it. There's a lot of photos in this presentation.
So we talked about those in the lecture. So there's kind of two choices for those pigment spots.
Yeah, we'll get into it. Yeah, so lots of photos kind of showing a lot of the same, highlighting the underlying choroidal vasculature. Keep that in mind. And here's the left eye.
Yeah, left eye, same exact sort of picture, maybe some cotton wool spots superior to the disc and inferiorly. Otherwise, yeah, same exact photo.
Yeah. A little rough spot there.
It does look a little, but I don't think so. I think it's kind of like yeah, I think it's, I don't say it's a rough spot, but it does look rough spotty.
Drusennoidish.
Yeah. It's like, I think it's like a cotton wool spot hemorrhage.
Yeah.
It's like a mix.
Yeah, just more of the same, really prominent, like choroidal vasculature, vortex veins.
Yeah.
Lots of great photos. All right.
All right. So OCT MAC of the right eye. You have the media looks okay, maybe a partial detachment of the vitreous there, or maybe it looks like an ERM. Or is
No,
yeah,
that's vitreous, right? Vitreous.
okay. And there also seems to be some hard exudate or some sort of hyperreflective material within the inner retina and outer retina as well. Some intraretinal cysts and some elevation to the outer retina, some edema and some subretinal edema as well, some RPE migration, especially subfoveally. The RPE itself looks intact and the choroid looks normal. Yeah, same exact picture
This is a
here.
vertical, I think, same one.
Yeah, I think it's a vertical.
Oh, vertical. Okay. Yeah.
Yeah, so this is the left eye coming up. Go back to that last left eye. Yeah, so what do you think in the middle there?
Yeah, in the middle looks like the ellipsoid zone. Everything is just very disorganized. It's hard to tell if there is, yeah, it looks like a subretinal fluid, maybe some exudate.
Subretinal or interretinal here?
Oh, I want to guess subretinal, but I'm not
I
sure.
think it's subretinal. So I think your retina is going here. Yeah, I think you're right. So your retina is kind of going here. And then you've got your side, and then you got junk in it, just because it's just an old cruddy. This has been going on a while.
Yeah.
So this isn't fresh.
You were just diagnosed today?
Yeah, 2020, but she just came in. I don't know where she's been. It's a little weird.
Yeah.
It's people are strange.
I agree with that. Just kind of showing the central macular thickness here, very edematistic, and
yeah, so OCT optic nerve.
So you're about 200, I think, 240. I can see the pictures of it like really close. So 228 in the right, 240 in the left, I think.
Okay.
So the nerves are a little swollen.
all right, getting into FA.
All right, so this is the early choroidal filling phase, maybe. Let's see.
Retinal, arterial,
Oh yeah, there's some. Yes.
Yeah.
Some arterial filling, and now we're in the laminar phase, heading towards the arteriovenous phase. Yeah, some hyperreflective, some capillary dropouts.
Next photo.
Yeah, and some leakage around some of those arteries, especially in the inferior arcade and within the macula as well. Maybe some aneurysms, microaneurysms.
There you can see that leakage better that you were talking about. It's hyperfluorescent, kind of.
Starry sky sort of appearance.
Sure, yeah.
Good morning, comment. Could you delay my schedule on that by about 30 minutes, please?
So here, this is like super temp, maybe where some of those hyperpigmented spots were on the Claris photo.
Yeah, it's and that photo almost kind of looks like there's some inflammation around one of those arterioles. So maybe some periphlebitis, maybe one of the veins, not the arterioles, the venules.
A diabetic though, they can look pretty funky. I mean,
That's
they can
true.
be. I mean, that's probably more venous beating, which you don't see that well. But then there's really. What about non-perfusion? You see a sweep, you're worried about non-perfusion.
Now, you said in the periphery, you can kind of have this non-perfusion look, but that's how I was interpreting it. It's
Right.
like,
Yeah, I don't think this is
kind of-
non-perfusion. I would not have called this non-per. This is just like dark shadow peripheral images. So I would
Okay.
not go with non-perfusion. If there's non-perfusion, usually you can see the border somewhere. You know, there's somewhere in there, there's gonna be there's gonna be a border between the non-perfusion and perfusion, not just this. It's a sharp border, is what I'm trying to say.
There is a non-perfusion up there.
Yes, yeah, it's
You
true.
would
If
see
you
the
go-
difference.
But some of those might be the hemorrhage. She's got so much junk going on.
Yeah, there's
The
a
cotton wool
lot,
spots.
going on in
Yeah.
these eyes. It's not just one thing, obviously.
Nice venous beating. Might pull that image for that too.
Yeah.
Yeah,
Rough
same
out.
exact kind of look in this eye as well, with the capillary dropouts, the venous beating, the microaneurysms, the leakages.
Some AV nicking, like serious AV nicking.
Yeah,
Yeah.
yeah, especially right there. Yep.
Yeah, you're right. I mean, it's not like supratemporal macula is a nice area of non-perfusion. Like that little dark spot. I think that's not a cotton wool spot. If you go up, I can do it actually.
Yeah, right,
there.
right there. Yeah.
That's a nice non-perfusion spot.
So. It's more photos. There are like 50 photos in the slide deck, so it's a big PowerPoint.
Look like 10 minutes, so keep going.
Yeah,
Keep me sketching the back.
okay. And then this is just kind of showing evolution over time. And she was actually receiving treatment, was getting injections with Avastin monthly. So you see there's a little bit of improvement in that intraretinal, subretinal fluid that we saw.
And what you would expect with chronic subretinal fluid, which is intraretinal fluid, which is, this probably is, you would expect it to take a while to go away because it's so thick. I don't know if you've read on retinal surgery, when you're draining subretinal fluid, it's so thick that and all the shots do is they stop leakage, but they don't enhance absorption as far as we know.
And just the other eye showing the progression. So summary, this 56-year-old woman with decreased vision since being hospitalized with questionable DIC and hypertensive urgency, emergency, as well as like an exacerbation of her diabetes when she was in the hospital, but better control with the diabetes currently. You talked about all these findings on the fundus photo, hard exudates, maybe some cotton wool spot, scattered dot blot hemorrhages and intraretinal heme, some AV nicking, loss of foveal reflex with some obvious macular edema. And then in the periphery, not kind of away from the macula, but kind of scattered throughout the posterior pole, you have these small hyperpigmented flecks with surrounding areas of depigmentations scattered throughout, almost in a streak-like pattern. And then with the OCT, significant intraretinal fluid, subretinal fluid, these hyperreflective foci in the inner outer retinal layers kind of correlate to your hard exudates and disruption of the ellipsoid zone and especially subfoveally in some of those photos. And then FA, I wasn't too sure. I thought maybe you were trying to illustrate delayed choroidal filling early on. And then obviously these scattered hyperfluorescent flecks with surrounding areas of leakage, patches of hypofluorescent and filling defects kind of scattered throughout. And then I was thinking maybe a wedge-shaped area of hypofluorescence in the periphery, illustrating kind of filling defects. But I guess you're saying that's just a common finding in the
I think it's just
periphery.
dark, yeah, it's just
Yeah.
optical. It's dark.
So just any thoughts off the top of your head for what you're leaning towards? You know, there are a couple different things going on.
The
with
main
this.
interest is the pigment spots.
Yes.
So looking at especially like the FAs, I would assume this is probably some sort of diabetic retinopathy. It looks like it's caused by something that would cause ischemia, so it'd be weird to have like a bilateral ocular ischemic syndrome, but it could present like this. Hypertensive retinopathy could present like this. The RPE clumping, I'm not sure why, maybe due to ischemia in the periphery that could happen.
Yeah, exactly. So she obviously is a diabetic with bad diabetic macular edema. And then she has these hyperpigmented spots. You mentioned hypertensive retinopathy that goes along with hypertensive choroidopathy as well. And so this is just kind of a good mnemonic for causes of CME with leakage on FA. So diabetes DME is the most common, which is what we saw with this patient. Some other syndromes to keep in mind. And then for the hyperpigmented spots, I was thinking like chororetinal scars from maybe a previous infection or ischemic event, especially given her history of possible DIC, hypertensive urgency, and then your Siegrist streaks and Elschnig spots, which Dr. Cohen briefly mentioned at the beginning of lecture, and that's what the focus of this case was. Other maybe causes of these hyperpigmented spots, age-related changes of the RPE, and maybe bone spicules with our retinitis pigmentosa. So yeah, that's the focus. So Siegrist streaks, Elschnig spots, they're manifestations of choroidal perfusion abnormalities, most notably hypertensive choroidopathy, most commonly caused by malignant hypertension. So acute elevations in blood pressure, typically over 180 over 120, with associated with end organ damage. So if there's no end organ damage, we know it's classified as like hypertensive urgency. So hypertensive choroidopathy can also be seen in preeclampsia, HELP syndrome, adrenal carcinomas that cause a acute spike in blood pressure. And then there's also inflammatory causes like an arteritis, GCA, Takayasu, and polyarteritis nodosa. So, I thought there were findings of both in this case. You just mentioned Siegrist streaks, but Elschnig spots, they appear as these small isolated circular areas with central RPE clumping with surrounding areas of depigmentation. So I thought, there were findings of both. The kind of way to differentiate is Siegrist streaks. They don't occur in isolation. They're kind of clustered around the choroidal vessels in a streak-like fashion, hence how they get their name. So early on, they can be more hypopigmented, more pale in color, and as they become chronic, these areas of ischemia, they kind of turn more hyperpigmented. And so it's representing ischemia of the choroidal lobules and that's why it's in these like streak lobular pattern. Elschnig spots. So this is, I saw more of these in this patient.
Yeah, I always thought they were spots, but then I read somewhere that the spots over the vessels are considered streaks. It's driving me a little crazy because I guess that's why I'm not sure. Yeah, I would have called them Elschnig spots 10 years ago, but then when I read somewhere about how they can if they're over the vessels, they're considered streaks, even though they're spots. But yeah, either way.
But I think they occur together because they're from the same underlying pathophysiology.
Yeah.
But so it would be fair to call it both.
Scott knows that. Scott's like Yoda.
So again, more pale early on, then it kind of becomes more hyperpigmented late. And then something else to look out for when you have a patient with choroidal or hypertensive choroidopathy, acute choroidal ischemia are these triangular wedge infarcts called Amelrip triangles. I actually saw one of these the other day in Dr. Bolia's clinic. Really well demarcated hypopigmented pale area of infarct. So other things you have to think about, I talked about severe hypertension, GCA, but DIC, which we have to think about with our patient, and then cocaine toxicity, ask about drug use. So Dr. Cohen mentioned this, but to understand the pathophysiology, think about the circulation and blood supply to the choroid. So keep in mind, the main blood supply is the posterior ciliary arteries for the choroid, which directly comes off the ophthalmic artery. There's 20 short posterior ciliary arteries and 2 anterior ciliary arteries, typically. And what distinguishes it from retinal circulation is that there's no autoregulatory mechanism and no blood ocular barrier for the choroid. So this makes it prone to damage with blood pressure fluctuation, especially elevated blood pressure. And Dr. Cohen did mention that at the beginning. So this is just a good kind of diagram showing kind of a cascade of events and how these develop. So you have your acutely elevated blood pressure, you have the fibrin platelet obstructions that develop, ischemia of the choroid arteries and choriocapillaris, and then obviously your non-perfusion kind of leading to Elschnig spots and Siegrist streak formation. There were no autofluorescents in this presentation, which I was surprised because you love autofluorescence.
I think they added it.
But basically, this can be helpful. You can see early on, there's like more of a granular pattern of autofluorescence, a mottled granular look. And then later in the disease progression, you get these hypoautofluorescent regions, which basically represents the RP atrophy. If you do visual fields, they can have correlating visual field deficits, and then OCTA, multiple flow voids corresponding to the areas of non-perfusion in the choroid, choriocapillaris. And then ICG and FA, it was hard for me to kind of find these areas. We can go back and maybe look at it more, but early on, you'll have leakage with patchy delayed choroidal filling. That's what I thought you were trying to demonstrate early on, like a delayed choroidal filling, which makes sense, right? If there's issues with the choroid, it might be a little delayed. And then focal areas of hyperfluorescence, representing window defects. And then when healed, importantly, these areas do not demonstrate leakage, but they can show transmission defects, blocking, which appear as hyperpigmented areas with surrounding hyperfluorescence. And then finally, management, is basically just treat the underlying cause. So management of hypertension, especially in this patient, and that's essentially the case.
Thank you, that was perfect. 10 o'clock on the 3rd.